Hi, good morning, everyone. Welcome to another series of The Doctor on Duty on the Parking Lot. Today I'm going to talk just briefly about emergencies in surgery. Most common emergencies that are for the purpose of the exams in the boards, as well as for the real test of life. So the most common scenario in this case, we're going to talk about a patient that has 25 years old that come with a pain, particularly started at the periumbilical area and is radiated to the right lower quadrant. This patient has anorexia, nausea, vomiting. It has when examined, the patient has a heart rate of 110, the small fever of 196 degrees Fahrenheit, and it has a blood pressure of 120 with 70. The patient has mild leukocytosis with 15,000, and it comes with appears still anxious in the bed. That is typical for the diagnosis that we all know at this point. So the diagnosis, of course, is appendicitis, based on the typical description of the right lower pain. However, we have to rule out, for the purpose of these exams, different other medical conditions. Goes from the cholecystitis, the problem urinary tract infection, the problems at the level of the peptic ulcer, particularly when it is perforated as a complication, the problem of a ectopic pregnancy, for example, which is in the case of any female sexually active, and less frequently, but still very important, Crohn's disease. So having said this, when we're doing these exams, basically what they ask you is, what is the next step? The next step, when it's so classical, the next step you can say directly, send it to operating room for the appendectomy. That's straightforward. Or they can ask you all sort of choices. For example, conducting a chest X-ray, which is basically done when you're suspecting a perforation of an ulcer, or conducting a CT scan of the abdomen, which is usually the gold standard for ruling out virtually any abdominal process or blunt trauma access when the person is stable in the abdomen, or conducting a ultrasound, for example, which is usually valuable when we are suspecting accumulation of liquid like a pelvic inflammatory disease or in a ectopic pregnancy. And so they can give you with all these instructions. You can, when you know already what it is, just go forward and just resolve the case. Now, another scenario is that it goes and say, well, you did actually open the patient, did the signature incision in the skin, and went into the appendix. But when you open it, when you see it, the appendix looks normal. So what is the next step? By the way, what happens in this case is that the ileum appears swollen, inflammation in the ileum. What do you do? In this case, what you had to do is, well, they give you the choices again. You close the patient, you put IV fluid, you put antibiotics, you send the patient home. Whatever choices, you have to know. Once you open the patient, you just complete the task. In this case, your signature incision is going to tell every other doctor in the world that the patient was appendectomized. So if at some point in the future the patient developed actually the appendicitis, they're going to be missing it because they thought that you remove it. So in this case, actually the diagnosis seems to be a new onset Crohn's disease because of the marked generalized inflammation on the ileum. But there is no contraindication for conducting the appendectomy, and you simply go and remove it from the patient. Now imagine another scenario with the same case, but when you access the appendix, what you're going to see is a inflammation also of the cecum. Now the question asks you, what do you do next? And when there is inflammation of the cecum, this is a contraindication for conducting appendectomy. The inflammation of the second, basically what you do, if you remove the appendices, this tissue is already swallowed, it's not going to be easy to heal, and therefore most likely it's going to be perforated, it's going to have some complication, and you don't want that. So there's basically literally a contraindication of conducting that, and you have to take medical treatment, namely the antibiotics, the IV antibiotics, the fluids, etc. Now, another case is a similar case with a patient that comes 22 years old that has a periumbilical pain that started with dyspepsia. And the patient has a particular improvement with antacids. And apparently there is a past history with similar conditions, and the pain does radiate to the right lower quadrant. Now, what do you do next? In this case, what we suspect immediately, because they give you the keywords of dyspepsia and the keywords of relieving the pain with antacid, we usually focus in the possibility of a peptic disease, a gastritis, or a perforated ulcer in the stomach or the duodenum. So basically, what we do in this case is X-ray. You can do an X-ray to see if there is a level of air under the diaphragm, which will be almost pathognomonic for this disease. If you have a perforated appendices, you can also have a little bit of air, but it's completely much more unusual to have this scenario. The other action you can do is to take a CT scan and to identify what is the condition in terms of the ulcer perforated. Of course, you have to also open and you have to close that ulcer, and back in the time we did the pyroroplastia and bagectomy. Usually they don't do it anymore. They have these medical wonderful medicines that can help the patient heal completely, but once it's perforated you have to operate. You have to make the diagnosis correct, differentiate the ulcer perforated from a appendicitis. Another cases can come, for example, a female sexually active, she says is having protective sex, but still comes with a pain in the suprapubic area that is also increased with the palpation to the right lower quadrant, and has guarding and has rebound. And so what you think is going to be the diagnosis? Just in general, they can have many other distractions, but when you identify those are the key elements from the diagnosis, and you immediately with these elements you're suspecting a ectopic pregnancy or inflammatory disease. So what is the next step? The patient has a normal blood pressure, meaning there is no such thing acute, no a risk of hypovolemic shock or septic shock right there. The patient doesn't have that great fever, it's not chilling, it sounds to be stable. So you can do the CT scan, and you in the CT scan identify the area of fluid collection that identify the pelvic inflammatory disease. So you can do the next step, which is using the pelvic, the CT scan to actually drain that collection if it is pertinent. Another case can come with a young boy, for example, 12 years old. I come also with a pain, but the pain is for 6 days, and it's a pain, again, abdominal pain. It does has guarding, it does has rebound tenderness. It started at the umbilical region and also radiated to the right lower quadrant. However, this case can, in some cases, create the confusion because it has 6 days. So what is the next step? They can ask you, just open the patient and remove appendectomy, conduct a laparoscopic appendectomy, conduct IV fluids and antibiotics. What is the next step? Usually, in this case, it's stable also, so we conduct a CT scan and identify what happened with the patient. And by the way, when you do the CT scan, let's say you identify there is a mass. The mass was diagnosed, by the way, by you when you do the palpation, and you found the keyword of dullness on the right side. So whenever somebody comes dullness in the right side, usually it's not a distraction. Usually it's a keyword to indicate that there is something, a fluid accumulated or some solid mass accumulated in that region. So that's important. Whatever they put in this tests are classical of what we see in the real life and what we do in real life when we're touching the patient. So the dullness is classical for this particular mass. And when they are asking you for all these choices is what to do next, and the next step in these cases are the you can go and observe the patient, how is progressing. If the patient is progressing because it's already 6 days and it's stable, so you have two choices. The patient can either evolve toward resolution of that mass by treatment, medical treatment, by fluids and the antibiotics, or it can evolve to the other extreme, which is the mass, the pus or the inflammation continues to decay and create trying to get into a fistula, or can create a worsening of the temperature, increasing the temperature, increasing the pain, lowering the blood pressure, immediately indicates that it's an emergency, so there is a need for other treatment. And what is the next step? Do you open surgically? Do you remove that laparoscopically? What do? The next step is, again, CT scan guided drainage of this phlegmon, appendicular phlegmon. So this is general scenarios how they present the cases in appendicitis. We're going to just go to the next step, check what are the most common traumas, the most common emergencies that we find. We're going to see that in the next minute, and I hope this is for some use, at least in the practical sense for real life, or for example, if it is your case, if you want to take the boards as well. Thank you very much and have a wonderful day.